from the East Coast, and thank you for standing by. I'd like to welcome you to our webinar, Risk Adjustment Roundup, reviewing the CMS call letter and other trends. My name is Sean Forster, and I'll be the moderator for today's discussion. Before we get to the presentation, I do have a few housekeeping items. During the presentation, all participants will be in a listen-only mode. Also, today's webinar is being recorded and will be made available on our website by the end of the week. Although lines are muted, we do encourage you to ask questions during today's presentation. To do so, please submit your questions using the questions pod, most likely located on the right-hand side of your screen. Simply type your question into the box and click send, and it will be sent directly to a meeting organizer to queue for the Q&A session we'll host at the end of the hour. Should you encounter any technical difficulties during the webinar, please also utilize this questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. Throughout the webinar, we'll also have a series of polling questions to gather your input. When we reach those points, I'll read off the question to you, and you'll be able to select from a list of options. With that, I invite you to sit back, relax, and enjoy today's presentation. I'm happy to introduce our speaker today, Pam Klugman, who brings with her more than 25 years of experience in healthcare. Prior to joining the CAIO team, Pam was co-founder and chief products officer of ClearVision Information Systems, a provider of software and services to optimize care and revenue for plans and providers across the country. Pam has served in leadership and oversight roles for Blue Shield of California, Blue Cross of California, Cedars-Sinai Medical Center, and Northridge Hospital. With expertise in system development, data analytics, and risk adjustment strategies, Pam is a recognized industry expert. Until recently, she was active in the Industry Collaborative Effort, or ICE, since its inception in 1998, and co-chaired the ICE Risk Adjustment Data Acquisition and Reporting, or RADAR, team for several years. Pam recently moved from day-to-day operations to her current role as a risk adjustment consultant for CAIO, where she tracks all industry announcements and regulations to ensure that our clients are aware of the latest trends and that those trends are also reflected in the solutions we provide. Here's our agenda for today. We're going to start off by reviewing the 2018 call letter that was released last month. We'll go through some of the changes to STARS quality measures, spend some time on Part C payments, a couple slides on the RAPS to EDPS blend, model recalibration. We're also going to look at 3 files and some changes to their layouts, the MAO-004, MMR, and MOR reports. And we're going to spend the last portion of the prepared comments on 4 actions that you can take at your organizations. And with any remaining time, we'll dedicate for Q&A, which we'll have at the end. And with that, I'll turn things over to our featured speaker, Pam.
Thanks, Sean. Hello, everyone. We're going to start off with a quick look at the CMS objectives. CMS has often said one of their objectives is to move away from the concept of being seen as a payer of claims, but rather be seen as a mechanism for the delivery of quality health care. The continuum of goals above reflects the high-level categories in which they are pursuing this objective. Improving the quality of health care can be addressed by STARS. Promoting alternative payment models is their way of seeking better avenues to reimburse for services to beneficiaries. Program integrity is addressed by RADV and various other type of audits. And improving the beneficiary experience is addressed by the various ratings around member satisfaction. There's absolutely much more detail to the activities within each of these goals. But today we'll briefly touch on some STAR changes for 2018 per the call letter, risk changes, as well as an in-depth review of EDPS and RAPS and their impact on payment. So what's staying the same in 18? Care coordination remains a focus of CMS. However, they are not moving forward with the triple weighting proposed in the advance notice. The CAI is staying the same without changes, and of note is that it actually had a small positive impact on the 2017 STAR ratings. BAPP will stay the same with changes to come in 2019. The EGWIPs, or EGWPs, are also remaining the same. Thankfully, no changes to Part C groupings and segmentation, but we'll review this in more detail. So what is changing? Let's start with some of the STAR measures. In an effort to improve the quality of individual care, I'm sure you are all aware, as plans get better at a particular measure or group of measures, CMS changes or drops them and adds new measures they feel need additional attention or are more challenging to health plans. With that in mind, let's take a look at a set of additions as well as deletions of measures. On the addition side, the medication reconciliation post-discharge, which is a Part C measure, CMS has included this measure on the 17 display page and will move the revised measure into the 2018 star ratings. CMS is considering rolling this indicator into a more comprehensive measure of care transitions along with other indicators. The measure will be classified as a process measure with a weight of 1 for the 2018 star ratings and will not be triple weighted as proposed in the advance notice. Improving bladder control, another Part C measure. CMS temporarily moved this measure to the display page in 16 and 17. They'll return this measure to star ratings beginning in 18. It will return with initial weight of 1. Some of the removals, high-risk medication or HRM, which is Part D measure. Based on feedback to the draft 17 call letter, the HRM measure remained in star ratings for 17. CMS will move this measure to the display page for 18 based on the 16 data and will continue to provide HRM measure reports to Part D sponsors through the Patient Safety Analysis website and to identify outliers. A Part C measure that is being removed is the reducing the risk of falling. It will remain in star ratings in 18. However, since the National Committee for Quality Assurance, which we know as NCQA, made several changes to this measure, the revised questions will be first collected in 18, and there will be no data for this measure for 19 and 20 star ratings. It appears this may be the last year for this measure in its current form. What we have here in this table are the CMS measures, display measures, for 2018 for Parts C and D. CAPS in C are the asthma measures are staying as display measures, several others that you can see on this page. So some potential new measures for 19 show an increasing emphasis on care coordination. If anyone would like a more in-depth review of the STARS measures, please let Sean know. With enough interest, we can put together a webinar with a focus primarily on STARS. For now, let's move on to risk adjustment. I like to look at risk adjustment and the changes we've had with the term fast and furious. Historically, as an industry, we've become accustomed to model modifications, which include but are not limited to adding, deleting, or changing diagnosis to HCC roll-ups, as well as recalibration. Recalibration of the model has typically been based on updated fee-for-service cost information. One of the more recent changes, which I like to refer to as the first of many accelerated changes, is the model change from version 12 to 22. Keeping in mind this was happening along with changes from ICD-9 to 10, which by itself was huge, with several false starts consuming a large amount of limited resources available for administration of healthcare. Next, we had a relatively fast transition, not only to a new model, but due to industry feedback, the blending of the old and new. This was followed by the introduction of additional data sources as well as the blending of those data sources. 2017 brought us segmentation of the community model with a dependency on Medicaid status, which can change monthly. There are a lot of changes, and it reminds me of the book Future Shock, which basically talks about our need to rapidly adapt to ever-increasing changes, which continue to accelerate as technology moves forward. So let's spend a bit of time reviewing a major change from the 2017 call letter that we're dealing with currently, which is the segmentation of the community model into 6 distinct populations. According to CMS, these changes will improve the precision of the payments made to plans, including increases in payments for plan servicing full benefit dually eligible members, and will support healthy equity and payment accuracies. The 3 high-level segments are non-dual, full benefit dual, and partial benefit dual, with each of these segments being broken down into aged or disabled. As many of you already know, the full and partial benefits for dual eligible refer to Medicaid status, Medi-Cal for those of us in California. And they are on a rolling basis, meaning that although Medicaid eligibility is on a monthly basis, for simplicity, and I say that tongue-in-cheek, they are revised for payment on a rolling quarterly basis with reconciliation at year-end. Indicators for the quarter status are supplied in the MMR. If you've done any deep dives from a technical standpoint, we'll also learn very quickly that reading the regulations and technical specs on what bucket, technical term bucket, beneficiary belongs in is not a guarantee that your calculations will be accurate. Experience has shown there are many factors that determine which bucket in which to put a beneficiary for purposes of payment calculation. Some of these cannot be gleaned from the text in the regulation alone. If you or your vendor merely programs from the published regulation, you may miss nuances essential for accurate payment calculation. So let's jump back here now to some of the changes to the Part C payment. We've looked at the segmentations for use for the first time in 17. Let's take a look at our old friend rebasing, also known as repricing. CMS is required to rebase the rates periodically, but, quote, not less than once every 3 years. CMS plans to rebase the fee-for-service county rates in 18. Based on the 2018 announcement, they estimate an overall payment increase of 2.95%, 0.45 resulting from trends, adjustments, and changes to stars, and another 2.5% resulting from improvements in coding accuracy. From the advance notice, we knew rebasing would take place, but at the time, CMS had not run the calculations necessary to estimate the impact. The final announcement reflects an estimated impact of the rebasing based on 2017 expected costs and a multitude of other factors that go into the calculation. Now let's take a further look at this and why we need to be very concerned should CMS ever reprice based on EDPS data from the MAO industry. Revised encounter data timeline is above. Payment year 18, originally scheduled to be 50-50 on encounter and RAPs, has now moved to 15% on risk adjustment and fee-for-service, with 85% using RAPs and fee-for-service diagnosis. PACE organization will continue in the same method that they've used since 2015, and in case anyone has forgotten, that is purely an additive model. So all data from RAPs and all data from EDPS will be additive. CMS has moved instead of 50-50 to 15-85 because they have identified there are issues with diagnosis capture from EDPS. If there's diagnosis capture issues, why can't we assume there's just as much, if not more, CPT issues, which goes directly to the repricing issue?
And before we get to the recalibration, we do have our first poll question. So if we could please launch the poll number 1. And this question is going to do with kind of a prediction, so get your crystal balls out. And on the call today, we have representation from health plans and providers across the nation. And although CMS has been silent on future EDPS and RAP split in future years beyond the table we had just shown you, we think it's reasonable to believe that it's going to be less than 25 and 75% split previously announced. So since it's not often we have so many risk adjustment professionals gathered, we thought we could crowdsource what our collective thoughts were on that next blend. So we have 5 options available. We have a 0-100, removing EDPS entirely, a 10-90 split, which would continue a rollback that has started this year, a 15-85, which would maintain our current blend going forward, 25-75, a slight increase from the current, or a 50-50, which would probably be the most significant that they'd be willing to go up to. So it looks like we have most people voting in here, so we'll just give a few seconds while we go ahead and close the poll and share the results. It looks like we have a majority, 39%, saying a 25 to 75% split, Next most would be a current status of 15-85% split, and a 50-50 actually has nearly 20% of the responses. So I don't know if your crystal ball, Pam, what you would anticipate. It looks like most people expect either the same or an increase from the 18-15.
Right. It could actually go the other way around and go back to 25-75, but I think that a lot of it will depend on the success they have with 15-85, and I actually think if the industry pushes back enough, they'll leave it at 15-85 for another year.
Okay.
At least I'm hoping. I would like it to go back to reps, but...
Well, that only got 2%. So, anyway, moving on to the recalibration, back to you.
Right. Well, and one of the reasons, if you look at it, the reason CMS wants off EDPS, wants off RAPs, is right now they're paying for two systems, RAPs and EDPS. And I think we've talked about this in prior years. The more quickly they can move off back to one system, they'll save money on their administrative costs. But at the end of the day, they have to make sure they don't totally disrupt our industry. So we're taking a look here now at the basics of calibration and why, if it's not forefront in your mind, you might want it to be. We have here an oversimplified example showing how the cost could vary between fee-for-service and MAO for the same conditions purely based on the CPTs admitted, since costs, as calculated by CMS, are always based on fee-for-service pricing methodology, i.e. CPT codes. So for years, we were, as an industry, we were pushing back saying, use our data, use our data, use our data. But so CMS said, fine, I'll use your data. But what they didn't say, the underlying tone is, I'll use your data, but I'm going to treat it like fee-for-service and price it like fee-for-service. So while they were looking at the services we performed, they were still pricing it based on fee-for-service. So repricing based on MAO EDPS submissions can potentially be far lower than anything we've experienced with fee-for-service based pricing. The example above shows a large disparity in cost between fee-for-service submitted CPTs and the MAO submitted CPTs, both for the same diagnostic conditions. Taking a look above, you can see that the disease cost using the fee-for-service CPTs is $1,173, while for an MAO for the same condition, it's $456. Yes, our risk score, as a raw number, could be higher than it is today, but if the underlying cost basis is lower, then the corresponding MAO reimbursement will be lower. A risk score of 0.980, for example, with a base rate of 1,000 is much higher on a PMPM basis than a score of 1.5 with a base rate of 400. The difference is 980 PMPM versus 600 PMPM for the same condition. Don't forget, CPT is the cost calibrator. In fee-for-service, payment is based on activities versus health conditions. So why does this matter? Because the deficiencies in submission of CPTs impact the perceived cost of treatment based on CMS's method of calculation. The fee-for-service industry has been working with CPT submissions since the 60s. They've had in excess of 50 years to perfect coding and submission of activities. We've had far less experience with CPTs. Our emphasis has always been documentation for conditions. People, industries, whatever you want to call them, we all get good at what we get paid for. Fee-for-service got good at CPTs. Managed care, healthcare, MAOs, whatever you want to call the health maintenance organization business, got good at diagnoses. It's important to keep all of this information at the forefront of our minds when we're working with encounter data submissions. To bring this home even further, let's just take a look at this one note. If you think CMS may not be moving in the direction of repricing based on MAO data, you'd be forgiven if you missed it, because it's not exactly something CMS is trumpeting. In our review of the CMS response to comments to the 2018 advance notice, within the coding intensity questions, we found this illuminating kernel of information foreshadowing CMS's future move in this direction. So we have to keep in mind, while they have moved back to 1585 for encounter data to use in the risk scoring, they're still getting all of our encounter data for costing, for pricing. This should give everyone much cause for concern. While the primary topic and question being answered is relative to the coding intensity adjustment, the more significant item to take away is a statement about MA encounter data to reprice the model. Again, for risk adjustment factors, the 0.9 or the 1.2 or the 0.3, they're using 85% RAPS, 15% encounter data for next year. But they're still getting all of our data. They're still looking at our CPT codes to figure out what our cost is for that diagnosis relative to the fee-for-service cost for that diagnosis. And I don't believe it will be higher. So let's now take a look at the MAO 004, and we'll just call them MAO 4s for brevity. Up here we have a timeline that reflects the numerous changes to the MAO 4 reports through April, May of 17. Let's look at a detailed review of the more recent changes, as CMS has made several more modifications. And it's important to note the CMS or the MAO 4s are somewhat analogous to a RAPS return, and as such, they should be providing all the information needed on what diagnosis codes have been accepted that will enable us to determine the accuracy of payment, current and future. During Q1 of 2017, CMS said they will rerun all prior MAO 4s, also known as the Phase 3 04 reports, with a new layout and with corrections to operational issues associated with the Phase 2, which were, by the way, just released in October of 16. During the first week of April, CMS was to send monthly reports beginning with the 15 date of service and then transmit the older 204 dates of service and forward in late May. We have seen some of the newer layouts with the more recent data, and we have yet to see any of the old 14 dates of service forward with those new layouts. So not sure what your experience has been, but hopefully people this week started seeing some of that more historic data. So what's the objective of another layout? According to CMS, their objective is improved reconciliation ability for plans and an ability to tie the O2s to the O4s. Additional detail on why a diagnosis is or is not eligible for risk adjustment, and includes diagnoses that pass as well as did not pass the filtering logic. Again, this makes the MAO4 much more in line with the RAPS return file in that you will know what diagnosis was or was not accepted. So let's do a little bit deeper dive here. As you can see, there will be much more detail to the reporting on the Phase 3 MAO reports. If you'd like additional information, you can review the CMS Risk Adjustment and Encounter Data User Group slides, and a link to the slides is provided and noted here at the bottom of the page. While many of you may not be familiar with the specifications for filtering encounter data, above is a slice of information showing inpatient, outpatient type of bill filtering, followed by some of the Phase 2 errors that have been corrected. So we won't be covering all the details, and you can see from the information on this slide that not only were fields revised, but there are many new fields. Many of the changes designed to provide more usable information for plans as the industry moves forward with encounter data. Revised fields have either changed the field length or added more specification. In other words, if you take a look at field 11, it's an encounter type switch. So now it can accommodate 9 different record types. The new field provides much more detail on diagnosis, acceptance, or rejection, which helps to make reconciliation with plan submissions more accurate for both accepted and rejected risk adjustable diagnosis, and provides insight into why diagnoses were disallowed. You should also be able to discern if the quarterly update to the CPT HCPCS list has had an impact on diagnosis acceptance for risk adjustment. For example, let's take a look at field 27. One of the filters CMS uses to determine if a diagnosis is acceptable for risk adjustment is the CPT. What I mean by that is each diagnosis has to be backed by a CPT code used in the CMS filtering in order to be used for CMS HCC risk calculation. Should a CPT code move from the non-allowable to the allowable, Field 27 will note the diagnosis associated with that CPT from prior submission and change it from disallowed to allowed. So what this means basically is that we are required to send all diagnosis and all CPTs associated with an encounter. The HCPCS CPT list is updated quarterly, and if an item moves in or out of that, CMS will automatically re-tag that diagnosis associated with that CPT to be allowed or disallowed. Much more information. Now, keeping in mind both the MMR and MOR are reporting data that is at least 6 months old, let's take a look at the details of these reporting changes. An example of the age of the information, the January 17 MMR MOR reflects data with a data service through June 30, 16 that CMS has in their hands as of the September sweep. Let's take a look at how CMS has modified the MMR to enable plans to actually obtain the details on each beneficiary's monthly payment for their risk-adjusted portion. Here's a brief overview for those of you who may not be aware of the MOR, MMR, and their usage for confirming risk adjustment. The MOR is mostly non-human readable as it contains a series of ones and zeros, each identifying if a switch is on or off. Each position means something different. There's a separate MOR for Part C versus Part D versus EDPS or ESRD/PACE. The indicator for Medicaid remains in the demographic section toward the beginning of the file, with the full or partial eligibility obtained from information reflected on the MMR. The MMR is recalculated 3 times a year, of which 2 of the changes impact monthly payment, and the final reflects the lump sum for the year, either plus or minus. In other words, there is a change in January of every year based on the new data, which is the June-July data. For example, 18 will be July 1st of 16 through June 30th, 17. We'll see that on January of 18. The July change reflects calendar year data that CMS has in their hand as of the previous March, and then the final, which does not impact a monthly payment, is in fact a recalculation of an entire calendar year data so that a lump sum final reconciliation can be performed with the plans. The MMR provides additional detail as to the specifications of the calculation, including but not limited to the RAF factor types, Medicaid status, etc. Some of the changes are to the MMR status fields. The combination of these 5 critical MMR fields are going to assist in determining the table needed to calculate the risk-adjusted portion of your payment. Remember what we covered earlier about the 6 segments in the community model. Well, there's lots of tables that go to the back end of those 6 segments. You need to determine which segment the member belongs to in order to get an accurate calculation of their payment. In addition, you must also take into consideration what is the anchor month in each quarter. For year-end reconciliation, you'll also have to know precisely which month they had any Medicaid status, be it full or partial. Field 21 determines if the member has dual eligibility included in the payment calculation, and Field 84 indicates what specific dual status the member has for that payment month, and on it goes. We put 3 imaginary beneficiaries up as an illustration of the complexity in determining payment. Each of these would be using a different table for payment calculation based on the combination of indicators on the MMR, MOR. Okay.
Great. That takes us to our second polling question of today. So if you please post that up. And this question is, and before we get into kind of the 4 actions to take, we have a question for the audience around what's the biggest challenge facing your current risk adjustment and quality programs? We have 5 options here. The first is that the shift towards encounter data, some of the challenges we know as an industry, there has been some problems here, hence why CMS has decided to roll back to that 15-85% split. Keeping up with CMS changes, kind of going through all the different things that Pam just went through on the call letter and changes to file formatting. The payer-provider collaboration, working with either if you're a health plan, the provider groups, making sure that they're getting in your members into the office, making sure all those diagnosis codes are documented accurately, engaging members, getting them in the first place. Perhaps you have a challenging, widespread patient population that has trouble getting into the office, or is it tracking and submitting data, which can be a challenge with all those different data drop-off points. So it looks like around 40%, 60% of people are voting here. So go ahead and give people just a few moments. All right, let's go ahead and close the poll and share the results if we can. It looks like we have really 4 of the 5 got a pretty significant response, but the largest one at 34% appears to be the payer-provider collaboration, which I know we have a couple slides on a little bit later, so we'll make sure that we'll spend a little bit of time on that. Second place is keeping up with CMS changes, no surprise there, and then about equal amounts in the shift towards encounter data and tracking the submitted data. Really the only one that didn't have a ton of response was the engaging members. So.
Okay.
Great. So let's move on to our actions to take.
So we're going to go over here just some high-level actions. People may have this in-house, outsourced, various ways to look at it. We're going to track first the transition to EDPS. Now, whether you do your analysis and calculations in-house, you use a vendor, you need to have a handle on the following. And we're using the screens that we have for examples only. First of all, the percent of members with an HCC reflected in RAPS, reflected in EDPS, and reflected in the 04. Because keep in mind, it doesn't matter what your system says. It matters what CMS says. So members with an HCC from RAPS, those are confirmed HCC side on the RAPS side. EDPS is what you believe you have in-house based on your encounter or claims data, and the 04 is what CMS believes you have in-house based on your encounter data. You need to also know, it would be also good to know what provider type your risk-adjustable diagnosis are coming from. The reason it's important to take a look at this is low inpatient numbers may suggest you are missing diagnosis from hospital stays. You should be able to drill down on any discrepancies to the member level. You should be able to see if it's an EDPS filter issue. In other words, you have an EDPS flag, meaning you have an encounter with the same data service and the same diagnosis as your RAPS file, but it didn't pass the EDPS filtering logic. And you don't have an MA04. Is that correct? It could be. It could be that the health plan's filtering logic does not emulate 100% CMS's filtering logic. That doesn't mean there's an error, but you need to investigate that. You could be having RAPS data, an EDPS flag, and a flag that says it passed the EDPS filtering logic as published by CMS, but you don't have an 04. Did it pop out on an 02? Did it get rejected at the door? If it didn't get rejected at the door, why wasn't it included? Something's missing, something's wrong. And then you could also have missing EDPS data. So if you have the RAPS and you have the 04, it just means that for whatever reason within your system, you don't have the claim that triggered that 04. You have to have it, so maybe it's a process situation. You should be able to view the variance in detail down to a member level. You should get the specific diagnosis with the data survey and the billing provider to track down and resolve discrepancies. Don't forget that although 2018 is lower use of EDPS, CMS's objective is 100% based on EDPS eventually. Jumping over to looking at a continuity of care and documentation report, while the preceding set of data showed discrepancies, this view of the data presents the dollar impact of inconsistencies of year-over-year reporting inconsistencies of year-over-year reporting of chronic conditions. Not only should you be able to understand the correct the deficiencies, you also want to know the impact they're having on inconsistent treatment of your members and the corresponding impact to revenue. Of note is that when you have this in a blended criteria mode, you can see if the data is missing from RAPS or EDPS, so you have a good idea of the potential financial impact of the data source discrepancies as well. This view, as with many of the others, can be from RAPS or EDPS perspective, as well as the appropriate blended perspective for the year you're reviewing and that you've selected. Again, whether you do it in-house or whether you outsource, you need this level of granularity in order to make sure that your payments are commensurate with services provided and that none of your members are missing services for chronic conditions. So how do you do this and also have high risk scores? Or high quality scores. So you have to have a mechanism required to understand the current status on the quality side. HEDIS dashboards are one way to do that. And if we magnify the row in red, we can take a look at how many members are within the criteria to be measured for the event, also known as the denominator, as well as how many actually had the test visit or whatever the measure was monitoring. From here, you can jump into an individual to see what the measure should have had, or what measure that member should have had but didn't, and now you can do your action planning. Again, this level of granularity is necessary on a concurrent basis so that you can take a look at your quality measures, your STAR measures, and be proactive, because this year's activity in quality as well as with risk determines next year's outcomes, if you will. They determine next year's revenue, they determine next year's STAR and HEDIS ratings. So why not take advantage of that information that you should have in-house and take a look at it. The same perspective should be given to your STAR ratings. Here we have some clinical STAR measures. We have how many members met these measures, how many didn't, and their appropriate STAR rating as a result. You should be able to take your providers and look at STAR measure completion by group over time. All these perspectives turn your data into information, and it's important to provide this information to the physicians as they're the ones actually performing these functions for our members. And it was interesting to note that one of the high scoring responses was provider collaboration. In my opinion, we cannot do too much of it in our industry. While the health plans may be the liaison with CMS, the providers are the ones that are actually hands-on with our members. And it's that interaction that the member reflects on when they're doing things like member satisfaction surveys. So the more information we provide to our provider partners, the more we enable them to be proficient and efficient with the member's time and their time. So we look at all these perspectives. We need to provide information to the providers. So wouldn't it be nice if we could hand them a simple format report to show the chronic conditions that have not been assessed and the quality measures that are still outstanding according to information that's received to date? So again, whether you do this in-house or you use a vendor, make sure you are able to supply current and actionable information to your provider community so the beneficiary can be assessed for both their chronic conditions as well as their quality gaps at one visit. It's easier on the member and less burdensome for the provider. How many times have all of us heard about a member's complaint that they had to go back 2 and 3 times? Because don't forget, with each of those visits, that member has a copay. So while the providers may like the fact that they each have a copay and they have to pay it at the door, the member doesn't like it at all. And if it becomes something that could have been handled in a single visit, your member services department will probably be getting phone calls. All righty, so let's jump now just a little bit into the 3 pillars that we alluded to a little earlier on the questions that Sean asked. Provider-payer collaboration, diagnosis documentation, and sustaining high quality. We've reviewed a lot of information. We've reviewed the changes in the model segmentation, with 2017 being the first year of implementation, the MAO modifications, both in 16 and already again in 17, some mods to the MMR and MOR to administer the new model segmentation, and ways to view the data and what you should be reviewing on an ongoing basis, whether it's an in-house or an outsourced solution. Now we're going to go over some foundational tips that we've covered in the past, because if you don't have the basics covered, it eventually will destroy your foundation. You can't have a wonderful, marvelous house built on a structure that is not solid. So let's briefly discuss collaboration. So collaboration, you need to know each other, okay? You need to take a look at these quadrants. So are you a high technology user and perhaps your partner is a high capital user? And maybe you put those together to help increase the risk adjustment sophistication of everybody. You have to build consensus, but in order to build consensus, again, you need to know who you're talking to. And by know them, I don't mean know their name and know that maybe they're the director or the CEO of a plan or a group, or they're the medical director, but what are they working with? How sophisticated are with their risk adjustment programs and policies? Can your use of technology help them with better use of human capital? We have to work smarter, not harder, and we have to continually fine-tune the collaboration and cooperation, because we're going to sink or swim together. I mean, Noah's Ark, if it gets a hole, we're all going down. So let's move on a little bit now to diagnosis code capture. Ongoing audits will help ensure data accuracy. For those codes lacking sufficient documentation, make sure they're deleted from CMS submissions. Make sure they're never sent, first of all, and if you do find they're sent, make sure they're deleted. Track and correct CMS rejections. Even if the diagnosis to the HCC has been captured so you feel you have your risk score covered, if you have an encounter that's rejected at the door, those costs were also rejected. So again, going back to the use of MAO data, encounter data specifically for rebasing and repricing, if they don't have our encounter data, they don't have all our costs. Keeping in mind CPT for costing, but also however many additional services we provide as an industry are not relevant for pricing, because they're only pricing fee-for-service eligible or allowable activities. So it becomes very, very critical not only to get everything in so they know what we're doing as an industry, but also get all those CPT codes in so that those that qualify, the cost will be calculated and we'll be able to have hopefully no bump, no negative effect when we do eventually go to repricing based on MAO data. The other thing to note for diagnosis code capture is avoiding the iceberg altogether. So the members with gaps in their care, they're the most visible. You can kind of see them. So you have to create suspect lists based on HCC and quality measure gaps. You have to do specific profiling providers and groups, because a low score does not equal a bad doctor. You have to look at root causes. You have to see, did you not get the data? Is it in their system? Did they code 2 when there's 5? Did they send you 2 when there's 5 in their documentation? Or is there 10 in their documentation and you captured 5 because your system can only do that? You have to look not only for members with gaps in quality and risk, you have to look at provider-specific concerns and see if together you have any global processing issues. Global processing issues can be hidden under the surface, as you can see from this diagram, but they can have a major impact, as we saw with the Titanic. So, sustaining high quality, Let's take a quick look at sustaining high quality. You need to measure prospective, retrospective, and this holds true for both quality and risk. Retrospective, administrative things, you have to go dig up. It takes time, it takes resources, and that holds true for both risk adjustment and quality. Prospective, you can invest more resources prospectively and build processes into your business. Sharing information, having transparency is critical. And again, integrating initiatives, risk and quality. So the question always comes up, what's the best way? What's the best way? Well, the best way is whatever's the most efficient with the resources, technology, and sophistication that your organization has. So many times you're going to have risk and quality not speaking to each other, which is a big mistake. You know, put those two together and you can have more efficiencies both internally and outwardly. So I'm taking a quick look at the time. We have a bit of time. Before we jump into the Q&A, I'm going to just spend a few minutes on supportive services that SCIO has to offer, and I promise this is going to be extremely brief. Many of you are already doing inpatient data pursuits, but if you ever choose to outsource or need assistance during a crunch, we have full service offerings in this area. Chronic conditions driving risk adjustment model are typically reflected at the end of the diagnosis string for hospital inpatient, and efforts to obtain these codes are critical. So what I mentioned earlier on is that if you have a low percentage of inpatient, maybe you're not catching all those items at the end of that string. And again, capture those diagnosis codes that are documented but not coded, but remember to always eliminate codes for which there's no supporting documentation in the medical record. Provider collaboration, big item here. If you need an end-to-end fully outsourced or part of that outsourced provider solution for outreach, both member and provider, we help with those activities. Very, very important to collaborate. And chart validation. Again, a service that we can provide should anybody need it. With all the scrutiny on medical records, an additional look at your medical records, hopefully minimizing the risk of missing data, but also minimize the risk of sending undocumented data. It helps prepare for RADV audits, and you know, the rest is history out here. So again, send what you have, make sure you sent everything you have, and make sure you take back what cannot be supported.
Great. Thank you so much, Pam, and sorry if we had a little bit of connection issue. I think the audio was coming through okay, but we may have had a little bit of issue with the slides. We have had a couple questions come over around, is this presentation recorded? Will the slides be made available? We will be making both the recording and the slides available. So some of the ones that we just finished at the end there, I think there's only 2 or 3 slides affected, but those will be posted along with the recording, typically by the end of the week, if not certainly early next week. And since you all registered, you'll be receiving a email communication when those are posted, directing you to where you can find those. So thanks everyone. We do have kind of just a quick recap. We took a look at the some of the key changes to the 2018 call letter, including changes to stars, payments, the RAPS and EDPS blending, and potentially the model recalibration that everyone should, hopefully as a key takeaway, have that in your mind as you're putting your process and your programs in place the next year. Talk through some of the key changes to lay out really the MAO and the MMR reports, and then those actions to take. So we organized them really in kind of 4 sections: the preparing for the transition to EDPS, looking at things you can do to achieve high quality scores, some foundational tips, and I'd encourage, if you are interested in more around that payer-provider collaboration topic, mention some of the key things today. But we had a whole webinar last month, in fact, on, I believe it was April 13th, but certainly in last April, where we spent the whole balance of our webinar on that topic specifically. So if you are interested, I encourage you to go back and listen to that, or reach out to us. We'd be happy to meet with you and talk around how some ways that we've seen health plans and their provider groups work well together. And then, as Pam was just mentioning at the end briefly, some targeted supportive services to supplement the things that you're doing at your organization. So we are entering the Q&A phase, but before we get to that, we do have our third and final poll question on kind of a topic we hadn't talked about too much thus far, and it's around reporting and measuring results. And maybe we can use this as people are submitting questions, to jump into that Q&A section. And the question is how do you measure the results currently in your risk adjustment program? Give again here a few answers. Manually pulling reports and spreadsheets, automated monthly reports using a software solution to look, log in and review whenever you like, or do you not measure results? Hopefully we don't have too many folks that fit in that last category, but it would be interesting to see kind of where we fall on the rest of the options listed there. So it looks like getting a good amount of the folks who have submitted. Why don't we just give go ahead, close results, and then share the results. We have a tie, actually, between those first two options, manually pulling reports and spreadsheets, and automated monthly reports. So I don't know, Pam, if you have any thoughts around where you've seen organizations that that have good processes in place and how they use those reports to effectively get that feedback into their organizations. I don't know if you have any thoughts around that as people submit their questions.
I think both methods are good as long as the process behind each of them is continually validated. Some organizations that are smaller may do it manually. Some larger organizations, by the mere fact that they don't have enough manpower to do it manually, do it in an automated fashion. And again, you can get good results from both as long as the processes feeding them are continually updated. And because if a process changes on the front end and you don't change your process on the back, be it automated or manual, to collect the data, then you're going to have a disconnect. So I think both of those are good.
For those that are pulling results manually, is there a certain time frame that you would recommend? I would imagine you don't want to look at it just once a year, but would once a week be too much? Is there a happy medium in between there that you would suggest?
Well, if you're providing feedback to your providers, if you're a plan and providing feedback to your providers, they're doing claims every week. They're doing claims every day. So quality, you probably should do it as frequently as you can, but don't overload them. In other words, you never want to give a provider something to say you need to do that when they know they did it last week. On the other hand, you're looking at CMS data. CMS updates, RAPs and EDPS can be sent ongoing, but those RAPs reports aren't necessarily going back to the doctor every week or every day. So I really think in general, monthly at a minimum would be good.
So we are getting a few questions in. So folks, again, if you go to that questions module on the right-hand side of your screen, type them in, we'll be able to get them. But our first one up here is kind of around that abrasion question that you're just alluding to. And it seems like this person has their risk adjustment team and quality team, I assume this is from a plan, in separate locations. And how do you kind of coordinate efforts in engaging with? Have you seen a team doing that well when it's not the same department? Yeah.
Well, that thing about get to know your partner, collaboration with the provider, get to know your teams within your organization as well. I think collaborative work is always better, so as not to be duplicative. So if the risk department and the quality department can get on the same page with the reporting, and what I mean by that is even if they do it separate, if they can accumulate that information for one handoff to a provider, then the provider can have the information they need while the member's in front of them, and not calling someone in for something for a health condition versus calling someone to come in for a quality measure. So separate or apart, I would try to have a unified front to the provider community.
Question here on medications. I will just read this and get your reaction. Meds that are in the RX risk calculations that might not be identified by pharmacy claims because they may be covered by a medical beneficiary.
Okay, so my interpretation of that question, meds in and of themselves are not included in any risk calculation. The diagnoses that you're sending on your encounter and your encounter claims, I'll say that in, on your encounters and your RAPs, those diagnoses feed into an RxHCC. So they're not necessarily the same diagnosis that feed the medical HCC, but the same mechanism is feeding both. So let's just take diabetes, for example. You may be taking insulin. Insulin doesn't have a CPT or diagnosis. Insulin itself doesn't have a diagnosis code. Diabetes has the diagnosis code. And the codes, again, that you send in for risk are used for risk, whether it's medical risk or the RxHCC. So I hope that answered this person's question. If not, please send a follow-up, and we'll be happy to get back to you directly.
I have a question here. If someone suspects that they have a data drop-off issue, where would be kind of the plan of action if you're suspecting that this might be the case, but you don't really know where to begin?
Okay.
Where would you?
So from the health plan perspective, the first thing you would want to do is if you think you have a data drop-off, the only analogy I can make to this is when I first started auditing, when I was a Medicare auditor, and we had a home office, 3 hospitals, and a skilled nursing facility to audit, and we had 3 stacks, 4 feet high of work papers. And my training auditor said, don't look at it all. If you look at it all, you're going to paralyze yourself. You grab one stack, you grab one section, and you go for it. I would say that to whether you're a plan or a provider and think you have a data drop-off. Pick a couple examples where you think it's dropping off. Go down to the most minute portion, a claim or a few claims. What do you have documented? What did you send to the plan? What does the plan show? Anybody on that whole spectrum can do that. If there's a drop-off, where did it happen? Did it happen because you had a lot of documented, but you didn't code it, so the plan never got it? Did you have a lot documented, you did code it, but your billing service or whoever does your process to get that information to your plan, did it go through an EDI vendor? Did it drop there? So you have to isolate it down to the components and then find out what component is causing the issue. And it can be many.
Where can we find more information about the layouts of MOR and MMR reports?
Good question. There is a publication, and it's updated a few times, at least twice that I know of, maybe more a year, called the Plan Communication User Guide, also referred to as the PUG. And if you just write in the Google Plan Communication User Guide, you can get to that document. There's the guide and there's the appendices. And the appendices has all the layouts for the daily, weekly, monthly, and yearly reports from CMS.
And then the last question we have here, unless there's any kind of final questions that get submitted here, is the yearly annual for seniors chart. It's been signed off by the MD no later than 30 days after the date of service, and they're, I guess, asking for validation. Is this correct?
Okay, so to my knowledge, and I preface by saying I am not a coder. I don't code, but I do know that medical records have to be signed off on the date the service is performed, with exception if there's a diagnostic that's been ordered by the physician and it comes back either confirming or not confirming the diagnosis. A physician can update the medical record for that. But I know of nothing that segregates yearly annual, like a yearly or an annual visit, and gives them any different rules around the physician signature. So 30 days is the very, 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 very outset of what you might be able to update if you got diagnostic feedback.
Well, I'd like to thank the audience for taking the time to join us today. I'd like to especially thank Pam for joining us and walking us through these slides here. If you'd like someone from SCIO to contact you about what you've seen today, you can simply visit us at the Contact Us page on our website. And as a reminder, again, today's session was recorded and will be sent along to you in the coming days. And with that, that concludes today's conference. Thank you again for your participation, and I hope you all have a wonderful day. Take care.